Hello, good afternoon. I'd like to introduce Dr. McCullough for today's session. Dr. McCullough is an assistant professor of medicine at Rush University Sleep Center. She specializes in the treatment of sleep disorders and serves as the associate program director for the Sleep Medicine Fellowship. As a clinician, educator, and a person living with narcolepsy too, she's passionate about increasing awareness of sleep disorders and optimal sleep health. Dr. McCullough earned her medical degree and completed her internal medicine residency at the University of Florida, go Gators, followed by her sleep medicine fellowship at Rush. She is board certified in both internal medicine and sleep medicine. She is a member of the board of directors for the Illinois Sleep Society and an active within the Advocacy Committee at the American Academy of Sleep Medicine, AASM. Dr. McCullough also has participated in patient outreach efforts with Project Sleep, including Doctors with Narcolepsy video and Narcolepsy Nerd Alert. Could I have narcolepsy? In her spare time, she enjoys fishing in Lake Michigan in the summertime, the abundance of live music in Chicago, and spending quality time with her family and friends. Dr. McCullough.
Thank you for that lovely introduction. And I'm just so thrilled to be here. Thank you to the Hypersomnia Foundation for having me. That was a pretty good introduction, just a little bit about me. You already heard a lot of this, but I work at Rush in Chicago. I'm from Florida originally, so a big Florida sports fan. And I was diagnosed with narcolepsy when I was in my last year of medical school after experiencing symptoms for about 10 years before that. And I wasn't initially thinking about sleep medicine, but the more that I was involved with treating patients and also around my teachers and peers, I realized how little sleep knowledge people had, but all my patients had sleep problems. So really sparked a passion in me to help people get treatment and be identified and diagnosed. This is me with a group of sleep surgeons and other sleep physicians discussing sleep apnea treatments at the sleep conference last year. So that's a big part of my practice, but obviously there's a big place in my heart for hypersomnia disorders. So I want to set the stage a little bit before we're talking about being strategic about your doctor visits and just talk about why these communication problems exist, particularly in patients with hypersomnia disorders. One, as I alluded to, is there's a lack of provider education and knowledge about hypersomnia disorders. There's also a different vocabulary that patients use or that understand versus the doctor language that you learn when you go through medical schooling. There's limitations in testing and just in general resource constraints for everyone. And this was my introduction, actually pretty much my only education about narcolepsy as a medical student. So essentially it's a less than 20-second video of this dachshund named Rusty who has narcolepsy, and the dachshund's trotting along. And then it talks about how it's a condition where you suddenly fall asleep and then the dachshund falls over. It doesn't really describe cataplexy. It's a very, very short video. And that was all I knew. So as a medical student going through medical school, I had no insight and was very shocked about narcolepsy. And we know in the media, hypersomnia disorders in general, it doesn't it's not an accurate portrayal of what they look like. And this survey is a little bit older now, the Awaken survey that was completed, but it asked the general population, primary care providers or physicians, and sleep specialists about various chronic diseases and what their knowledge was about them. In the general population, 70% of people said that they had heard of narcolepsy, and only 50% of those 70% actually believed it impacted the overall health of a person, and 55% thought it was very or extremely serious condition. In primary care physicians, A quarter felt very or extremely knowledgeable. 7% could identify all 5 key symptoms. Less than 10% felt very or extremely comfortable with the diagnosis, and less than half could recognize 2 prominent narcolepsy symptoms. So I know there's a lot of, as a patient, you feel like, why hasn't my primary care doctor asked me about my sleep, or why haven't, I've been seeing them for years, how could this go misdiagnosed for so long? But there's just a lack of understanding and a lack of education. And the sleep specialists at the time, and only a third of them were board certified. There were people practicing sleep medicine that didn't have to pass the board before. A little over half felt very or extremely knowledgeable. Less than a quarter could identify all 5 key symptoms. Less than half felt very or extremely comfortable with the diagnosis, and a little over half could recognize the 2 prominent narcolepsy symptoms. So a lot of work to do, and I think that a lot of positive work has been done, but just very telling. So a little bit more recent survey of physicians and their perspectives of idiopathic hypersomnia. A little over a third believe that other physicians had a sufficient understanding of idiopathic hypersomnia. So the doctors are aware of this problem, as well as you all are. And over half felt that they personally mismanaged IH. 86% thought patients with IH were often misdiagnosed with depression or anxiety. 87% said diagnosing IH is challenging, and I will say myself that I agree with that. I would be a part of that 87%. I'd love to talk to the 13% that didn't think that. And then about 40% reported that it takes 2 to 5 years to get an accurate diagnosis, when we know that it actually takes much, much longer than that. The other thing that this survey showed is that the physicians agree that more education and resources are needed for people with IH. So I want to emphasize that, this is a smaller survey of 300 physicians, but they really care and they really want more awareness through the medical community and the general population about idiopathic hypersomnia to help your lives become better. There's also a big language barrier. You go through medical school and you learn this whole new, it's like learning a different language. And you learn about these key terms with certain diagnoses and certain conditions. But patients, your life experience doesn't necessarily fall into those categories. So this was a great article, and the slide's a little bit busy, but just exploring some different terms that you might say to your doctor, like, oh, I'm falling over. You say that to your primary care doctor. They might be worried about, like, do you have a torn ligament in your knee, or do you have something else going on? And cataplexy probably won't cross their mind. The other thing is, this goes back to how the testing and diagnosis is challenging. The test-retest reliability for the sleep studies in narcolepsy type 2 and IH is not good. So these are a few studies by Dr. Trotty, who spoke earlier today. The first one looked at patients who tested positive with the PSG and MSLT twice. And narcolepsy type 1, 91% were able to do that. So it's fairly reliable for narcolepsy type 1, but less than half of those in narcolepsy type 2 and IH. In another study with 36 patients, I think all from Dr. Trotty's patient population, over half of the patients had a change in diagnosis with the 2 tests, and only a third of the patients with narcolepsy type 2 had a second positive MSLT. So we really need alternative ways to diagnose this. It's not reliable. And I'll have people come in and understandably frustrated, like, hey, like to do this testing again. But this is another reason why we may be able to pick up something that we weren't before. And also it's just confusing. So we need more tools. Right now there's, you can do sleep diaries and something called actigraphy, which is estimating your sleep and activity. And if you estimate that you're sleeping for longer times over 7 days, you can make the diagnosis of IH. Actigraphy is not reimbursed. It's difficult to do and technically in some of the labs, and so that's not always done. And 24-hour sleep study is another way, but that's also, there's some challenges with insurance, and in the United States, that's not, reimbursed. So that's another thing that we run into. Also, something to just point out is a lot of your clinicians are being forced to see a lot of patients in a shorter amount of time. And it seems to just be getting worse. I'm giving my personal perspective. I've talked to some other my colleagues at different institutions, and they're experiencing something similar. Your doctor may have different limitations, but exploring this a little bit and finding out may be helpful for you. This is an example of one of my schedules. We have a certain no-show, quote unquote, rate. So we have to have 2 patients at once, and sometimes they both come. And as you can see, pretty much everybody showed up. There was somebody that didn't come, but it's 14 patients in a day, and I have an accommodated schedule because I have narcolepsy, so I can't do 17 or 18 patients or 19 patients in a day like my colleagues doing, but that's hard on everyone. So if somebody's running late or they feel like it's really quick, this might be why. It's not because they don't want to listen, just something, it's really unfortunate, but something that's happening. So in light of these challenges, how can we prepare and be strategic to come into the doctor's appointment, make the most out of it, so that you are improving to the best that you can? So I'll start by talking about how your doctor takes a history, talking about maybe some prep work that you can do, and then setting your goals and managing expectations. So when they go to medical school, you start taking patient histories your first year. And the most important thing is to start with an open-ended question, like, what brings you in today? What is the most important thing that you want to talk about today? And leaving it open-ended. So thinking about what is your most bothersome symptom, I think would be really important to kind of put out there out front. And leading from that, the doctor may ask you a lot of questions about, this is one of the mnemonics we learned, there's tons of mnemonics, but asking about that particular symptom, some characteristics of it. So onset, like, was it gradually starting or did it happen suddenly? Let's say it's sleepiness, for example. Was it sudden onset? Did it happen gradually? Location, this is oftentimes, a lot for pain, but if there's something with a location like cataplexy, if that's your symptom, is it in your knees or in your jaw? Duration, has it been going on for 3 weeks, 3 months, 3 years, 10 years? And characterize it. I know we were talking about how brain fog is different for everybody, what that exactly means, or the sleepiness or fatigue. And talking about it, if you can give real life examples, that's very helpful and can be very impactful. For example, if you are getting written up because you're not making it to school on time or work on time, if your child's not able to get to school on time, if you're having trouble in your romantic relationships or friendships because you can't show up to be there for that person, you don't have the energy to go out or do anything with them. Or like, is your safety in terms of driving an issue? Are you hitting those the things on the side of the road that tell you, hey, you're drifting off, or are you driving into traffic? Things like, does anything make it worse or better? That's this alleviating or aggravating or relieving or radiating. The timing, is it worse in the morning? Is this sleep inertia or sleep drunkenness that's, and then it gets better? Or do you feel exhausted, sleepy, tired all day, can't stay awake all day? And then severity, and that goes with some of those real life examples too. If you're not already kind of tracking symptoms, about and there's not data on this, but this is just me, my clinical experience, and my as a physician and also as a patient, I found this to be helpful. Kind of taking stock a couple weeks before your appointment, and each day at the end of the day, just reflecting and writing about your day, thinking about what was your most bothersome symptom and how, like, specifically did that impact you or change your day or challenge you. And then also, I think it's important to reflect on 3 good things that happened that day. Um, just in general, I find that uh, living with something that makes you so sleepy and exhausted, it can be easy to forget about the good things that you're able to do and the other things that you're able to accomplish. And Dr. Morse had something up about, self-esteem and different, I don't think imposter syndrome was up there, but I think we're doing more things than we give ourselves credit for. So reflecting on those things, I think, is important. Consider an activity and sleep journal too. The Hypersomnia Foundation has a great one on their website, where you're, putting in some concrete times of when you went to bed, what time you're getting up for the day, anything that impacted your sleep and wake times. The other thing is contacting a family or family member or a friend to accompany to your appointment. Most people without hypersomnia disorders remember 2 things from their doctor's appointment, and they don't have the brain fog or some of the other issues. So that can be very helpful, but you want to make sure you give them enough time to plan for that. And if you need an interpreter, request it before the time of appointment. Doctor's offices, if they haven't arranged for that, they often have phones and different things that are more virtual, but I find the person there, if they have it, is more useful. So the day before your appointment, kind of go back and review your notes from the past week or even the couple weeks, and then summarize on a single page what is the biggest thing that's been impacting your life recently, and give 1 to 2 real life examples of those challenges that you experienced. Think about, hey, your values and what's important to you, and what are 1 or 2 just achievable goals, which we'll talk about that in a second, of something that you'd want to accomplish. Reviewing your notes, you can write your typical bedtime, wake up time, hours of sleep. Those things are helpful for us to know as well when we see you back. Are you having interruptions in the middle of the night and duration of awakenings at night? One thing I'll add that's not on here, but I was talking to Dr. Munt, who's sitting back there, and I do think that, if you're having very debilitating nightmares or you're having these dreams, you could put those in the sleep diary too and bring those up. And then if you have any kind of lingering questions, concerns, write all those out and then prioritize what's most important. And remembering and thinking about, okay, like I have just this limited time. What is the most important thing that I need answered? Other things that are helpful for us are having your list of medications, supplements, and doses, setting aside that 1 pager and maybe a notebook and pen for you to write notes during the appointment. Get lots of rest before your appointment, and then confirm with your family or friend joining you for the appointment. So this is something that I've talked about in my training, SMART goals. I don't know if they do this in other non-medicine areas. I presume that they probably do, but this is like when you're making a goal, making sure that it's something specific, something that you can measure and know if there's any change. Is it attainable or, realistic? Is it relevant? And time bound so that you have something to monitor or measure. For example, if you care about having quality time with your family and you like cooking, then maybe say, I'm going to do this once a week. You're not going to do it every day because that seems like it's not attainable and it's too much. During your appointment, have the 1 pager ready. Think about your goal. Be open and honest, but also like we talked about, prioritizing, be as concise as possible. Ask questions if you don't understand. Write down these action items, and hopefully your doctor is also giving you some handouts or different things that talk about the changes that you made. I'm doing a discussion group with Dr. Munt and Matt Hornsnell and Lindsay Justed for the clinicians as well, to help them better be able to address you all during the appointments. And then scheduling this follow-up appointment before you leave the office or as soon as possible is really important, just because we get, but after the appointment, just reviewing your notes and goals, reflect on your action plan. If you have it written down, you can come back to it and say, hey, was I able to cook that one dinner a week with this? Maybe there was another medication added, or there was some change in your treatment. And then you have that to look at as, oh, I got better. And it's not the Epworth Sleepiness Scale or different things that are harder for you personally to track. You can send a message to your doctor. And then, is your doctor a good fit? I would say give them a chance over a few, sessions a few times. Not everybody's a good fit for everyone. With the time crunch too, if you're able to just remember that it is a longitudinal relationship, and so you'll have time, if you don't get to something today, maybe the next visit you can. That's important to remember, but sometimes it's just not a good fit and you need to move on. So I'll leave these takeaways up here and just leave it. I think I have like 3 minutes. If anybody had questions or thoughts they wanted to
raise your hand really high and we'll come over to you with a microphone so you can ask your question.
What should you do if your doctor undiagnoses you after a second sleep study, even if you still feel like you should have the diagnosis? Like, I was diagnosed with narcolepsy and then undiagnosed by the sleep study, but I think I have IH. So what should you do if that happens?
And the study was normal? The second study was normal, or it said IH? Was it narcolepsy type 2 and IH, or was it?
For those of you online who couldn't hear that, she basically said it was a bad sleep study.
Yeah. And that is really tough and speaks to this problem we have with testing. And I think if your doctor's taking your concerns seriously and treating you and you're doing better, that's one thing. But if you feel like, oh, now they're saying that nothing's wrong, and that's consistently happening, then maybe finding another look. Yeah, it's unfortunate.
One of our online attendees is asking, how can I efficiently educate my PCP and other healthcare providers about treatments such as Xywav? There is a true lack of awareness in this person's experience, as well as the time limitation, like you mentioned.
Yeah, that's a great question. I think this is a true problem. I think, even just a one-liner about how, if this is true, if your sleepiness is better with this oxybate medication, it's been really helpful. You leave that with them. They may think about that later and hold on to that. We in the sleep community as well are trying to do outreach to other disciplines, primary care providers, to provide more information about the sleep disorders and treatments. There's a lot of misinformation and misunderstanding and lack of understanding. But if you can just leave that little nugget, I think that would be helpful.
Awesome. Thank you. And we have a couple people. I'm sorry. Yeah, Dr. Mutz, let me bring you a microphone.
I think depending on the situation, this is a place where maybe your sleep physician can also advocate. So maybe if your PCP is recommending something that doesn't make sense, maybe rather than you as a patient tell your sleep physician what's going on, the sleep physician can then consult with the PCP and explain what's going on. That's a common thing physicians do, is like consult with each other because they don't know everything about a different specialty. So yeah, looping in your sleep doctor might be helpful.
Yeah, that's a really good point. Thank you so much.
That's a great point. And that was two of our next questions was about the collaborative decision making. But I like your suggestion about having your specialist contact your PCP about that.
Yeah, I agree.
Unfortunately, we are out of time, everyone, but let's go ahead and give Dr. McCullough a big round of applause. Thank you so much.
Thank you for having me. And then I know we're out of time, but one thing to add is, and you all are here and plugged in with the Hypersomnia Foundation and all the patient organizations. I think that's so important for you all and for everyone. It's a great way to spread awareness, but also just create that community and to add some extra things that the doctor might not be able to do during that visit. And thank you.